Welcome back. We are going to do part two of chapter one. So let's get started on that. We left off on like all the requirements of life. So now we're going to move into the next section, which is something you need to just really get to know because it's going to be there for all of your, if you're going into medical career, for all of your medical career, and that's basically homeostasis. Homeostasis by definition is just maintaining this constant internal condition. It's what we do all the time. When it is not maintained, that indicates there's something wrong. So that's disease, that's disorders, that's a problem. So what is not in homeostasis is going to be the problems that you need to look at. So how do we maintain the normal in order to determine what's abnormal? So our body has to stay in homeostasis. And generally, when we look at it, it says constant internal conditions. That's probably more of a misnomer. It's not really constant. It's within a range. So again, this 98.6 as far as your body temperature, you can go a little above, you can go a little below. As long as you're within that range, you're good. Okay, it doesn't have to be right here all the time. It just needs to be within that range. But if it goes outside that range some way or another, that's when it becomes a problem. And most of our systems, our body systems, work on some sort of homeostatic type of mechanism. Blood pH is one of those. Your blood pH is around a 7.4-ish. Again, it's a range. So 7.35 to 7.45 is really the kind of range that it can be in. So we sort of average it and say 7.4-ish, right? The body temperature I talked about. But there's all kinds of other mechanisms too. Basically, we have to have a way of always monitoring what's going on in our body, monitoring our systems and saying, is it normal? Is it going too high? Is it going too low? If that's the case, I need to do something to tweak it right now before it gets out of control. If I get way too hot, it's much harder for my body to cool back down than if I'm within this range and I'm just kind of eking up here, getting a little bit warmer. Then, make a little change and get back down more to a normal scale before it gets out of control. So you have all kinds of little monitors around your body that constantly make little checkpoints. Are we good? Are we good? Nope. Do I need to make a change? Do I need to tweak this a little bit, get back to normal so that you're not going outside of whatever that variation is, whatever that limit that your body can handle. If you do go outside that limit, you risk damage. So if I get too hot, I'm going to start damaging my cells. If I get my blood pH gets down below 7.35, it's not quite to the acidic range. That's below a 7, but it's moving towards the acidic range. Whereas if it gets above 7.45, it's getting too basic, and that's going to do damage to the cells and to how the cells work. And what really becomes a problem there. So how do we regulate this? There's 3 different parts to that mechanism, that homeostatic control mechanism. And we're going to talk about each more on the following pages. You have to have a receptor, something that receives the information and monitors all the time. You have to have a control center that says this is where we should be and this is how we're going to get there. And then you have to have an effector that actually is the work. If I need to have my body temperature around 98.6 and it's going up to 99, how do I get back down there? Control center says this is how you do it. The effector is the thing that's going to actually do that to get you back down there. So start that sweating mechanism would be the effector. Okay, so first, receptor. Receptor is constantly monitoring what's going on. So you have receptors for body temperature all over your body. You have receptors for blood pH in different parts around your body. So when the blood runs through there, it says it's normal. It takes a little census of it. Normal, nope, yes, whatever is going on there. And then it always provides information back to the control center. So it's always providing this information back. If the control center then says, this isn't right, it's going to have to determine what is right and how do I get back there again. So the control center is the boss, basically. This is the thing that this guy reports to him, right? And then the control center says, this is where we need to be. This is how we need to change it. And the control center then tells the effector, this is how you need to go about making that change in order to restore where we should be so that we don't get out of control here. All right, so here's your receptor. Little diagrams. I like diagrams. picks up a stimulus, so temperature change went up, something like that. So the receptor picked that up. It reported it back to the control center. The control center says, oh, we should be at 98.6, but we're really at 99.0 right now. Not too hot, but something to think about. So what do we do this? Let's tell the effectors to start the sweating process, start the dilation of the blood vessels, get rid of some of that excess heat and bring us back to normal. Stimulus would be back at normal then. So your receptor would say, we're normal, we're good. And then the control centers, we're all good here. Okay. So, but it's constantly doing this so that you don't get out of control, because if you start increasing 99, 99.2, 99.4, it's going to be rapidly become a problem. So you want to make sure that it doesn't get outside of that range too quickly or before you can take care of it. So it's a constant update process. There's a couple different homeostatic mechanisms. Type 1 is what we call negative feedback, and this is always coming back to my set point. So here's my range, right? My set point somewhere in the middle. I always want to make little adjustments to bring it back here. So if I go too high, make an adjustment to bring it back down here. If I go too low, bring an adjustment to bring it back here. So we're constantly doing this, bring it back to this point right here. So always coming to our set point, okay? Negatively responding to things. This is the most common type of feedback mechanism. This is the one that most of your body organs work on. Try and stay within a normal range. If you get outside the normal range, you're in trouble. So let's stay within that range and make small adjustments while we still can, okay? This is also how your thermostat at home works, or your air conditioner at home. We're in Houston, probably be better to say air conditioner at home, but this picture has a heater, so we'll go with that. Okay, so your room temperature is set to be at 66 degrees, which I would be freezing, but anyway, it's set at 66, right? So your thermostat is always monitoring and says, I have you set at 66. Doesn't mean my room temperature is going to be necessarily 66, but it's going to be a range, 64 to 68, somewhere in there. If it drops down below 64, that tolerable range, right? So now I'm okay with 64 to 68. I just want to be at an average of this. If it drops below 64, I need to make a change. So it tells the heater, turn on, heater puts out some heat, temperature goes up. Notice it went up to 70, and the thermostat say, whoa, wait, a little bit too high, shuts down, and it's not putting out any more heat, and the room starts to cool down. So really what you're doing is you're not staying at this set point of 66. What you're doing is you're going a little warmer, a little colder, a little warmer, a little colder, a little warmer, a little colder. And if I average all that out, I'm at 66. But I'm never, just sitting there at that point. I do hit that point, different points, but I'm not sitting there at that point. I'm always just a little above, a little below. But you average out within that tolerable range that has been dictated by that control center. We call that type 1 negative feedback. Any change that's too much is negative or creates a negative reaction, so it goes the opposite direction. That's why it's called negative, okay? The opposite of disorder, basically. So here it is again. And this one, in this diagram, it's set at 68, a little more comfortable for me. So 70 says too warm, cool down, and goes up and down. But again, you average at 68. You don't really sit at 68. It's not always at that point in there. For your body needs to do the same thing. So if I get too warm, so here's my set point is 37 degrees Celsius. In healthcare and every country pretty much except the United States, they use Celsius. In the United States, we use Fahrenheit. So 98.6 is Fahrenheit. 37 degrees is what it is in Celsius. Okay, so same thing. It's a different measuring system. So here we are at 37, right? If I walk outside in Houston, my temperature is going to start raising up because it's hot out there. So you're going to pick up that heat. That heat's going to start overheating, and your body says, whoa, wait, it's too warm. So you do things to rectify that. Like I said, blood vessels dilate. That allows blood to move to the surface. That's that flushing. You see the blood at the surface of the skin. Sweating occurs. So the water picks up the heat and moves to the surface from those blood vessels, and then it releases out of the environment, taking the heat with it. So you begin to cool down, and then you cool down and you drop below 37 at some point. It gets a little too cold and your body says, wait, too much the wrong direction. We want to stay right here. So before we get too far the wrong direction, we're going to go ahead and rectify this now. So you constrict, that means they get smaller. So constrict means they get smaller. Your blood vessels constrict where they dilated earlier, vasodilation. This is vasoconstriction. They constrict. That means less blood flow. You don't see that flushing anymore because you're pulling that blood away from the surface, and you stop sweating. And then in addition to that, you start to make those muscles contract, which is shivering, and that creates heat. And so you can release some of that heat into your body, and your body warms up again. So you kind of alternate between those two, not the two extremes of like profuse sweating and profuse shivering, but a little bit in between those two, and you constantly maintain at a normal. So you're a little bit warmer, a little bit cooler, a little bit warmer, but you're not overly one way or the other, right? Because if you get to the point where you're overly one way or the other, you're really kind of hitting the end points of it. So like walking outside at Houston, you're going to start sweating right away because we just hit that too high point. All right, so as a summary then, negative feedback is always trying to maintain normal. So we're always trying to maintain normal limits, right? Remember, it's not a set amount, it's a limit or an area between this. So here's where my limit, my norm is, my homeostasis. I can stay anywhere between that, right? So we want to maintain these normal limits. So in order to maintain normal, it means you're preventing sudden severe changes. I'm trying not to do that. I don't want to go, here's my upper end of my heat, here's my lower end. I don't want to go too far above it because I'm going to have to make some severe changes to get back to normal again. I just want to go, if I start to go that way, come back down very quickly and get back to that normal. Keep your body from working too hard by having to overcompensate for severe changes. So what it's doing in effect is now your effectors, those muscles, those sweat glands, whatever it is, don't have to work as hard because they're just working little amounts all the time. So working a little bit all the time is better than working a whole bunch once in a while, right? So we reduce the amount of action that these guys have to do by making them work a little all the time. Always correcting to that set point, 98.6 degrees Fahrenheit, 37 Celsius, or 7.4 on your blood, sort of within that range. So always correcting back to that by making these minor adjustments all the way along the way. You're keeping your body from being disrupted. So it's the opposite of disruption. That's where that negative comes back. We're always going, if we go one way, we go opposite direction. So you're opposite of too far away. I'm not getting too hot. I'm just getting a little warmer and a little cooler and a little warmer. So opposite of disruption, okay? Limiting that chaos. You don't want to get too far out of norm. You're trying to stay at normality all of the time. Stay some sort of stability within your body. And again, I mentioned this earlier, it is our most common feedback because most of the time we don't want major changes in our body, because if we have major changes in our body, then we're going to have disruptions we have to correct. And that becomes too much work on the body to do that. And sometimes it doesn't cope with it very well. So body temperature, blood pressure, again, if your blood pressure drops, your heartbeat's going to go up. If your blood pressure goes down, your heartbeat's going to go down. If you determine there's too much oxygen or too little oxygen, I should say, in your blood vessels, then you're going to start breathing heavier, right? So it's constantly making those adjustments to stay within a normal range. Glucose regulation, insulin is one of those things. Insulin, if you detect that you have too much glucose in the bloodstream, insulin is going to store that glucose away into your liver and your muscles in the form of glycogen, so that you don't have the free glucose. It's stored away, so we can stay within normal limits. Too much glucose all the time is going to cause damage to the cells. And likewise, glucagon works the opposite. So again, I drew this a little bit earlier. So here's my normal set point, 98.6-ish, right? Too warm, I'm going to sweat, bring it back down. too cold, I'm going to shiver, bring it back up. So we're always trying to come back to this point right here. And so we do minor changes to stay there. Up, down. It's this figure eight sort of look to it. Type 2, since we had a type 1, you know there had to be a type 2. Type 2 is what we call positive feedback. Positive feedback is necessary. It's extremely necessary, just as much as negative feedback is, but it's uncommon. This is one that is used for special circumstances only. And the reason is it's self-amplifying. In other words, when I go away from normal, so with say negative feedback, here's negative feedback right here, right? If I go away from normal, I'll come back down. If I go down, I come back up. So I'm always coming back to this set point right here. With positive feedback, if I go away from normal, it actually tells me to, oh, do that again. Go a little bit further from normal and go further from normal and go further. So I keep amplifying that response. Once that crisis is over, whatever it is I'm trying to finish, then I'll come back to normal. But I have to get to that point of finishing whatever it is I'm trying to finish, okay? For example, childbirth. If you have a child going into labor, right? You have a contraction. Your contraction then stimulates, and it has to do with hormones and stuff, but the contractions stimulate harder contractions, faster contractions. So harder and faster, harder and faster, harder and faster. Baby's born, stop, okay? So for that time being, that short-lived term, even though it might be like a 12-hour labor or whatever, it's still considered short-lived in your lifespan. For that short-lived time, you had to get away from normal more and more and more and more in order to complete that action. If, on the other hand, childbirth was a negative feedback, every time I had a contraction, I would stop. So I would keep stop. You'd never have the baby, right? I got to make those contractions harder, faster, harder, faster, harder, faster, have the baby, then end it, right? Blood clotting's the same way. It's an emergency situation. You've got to cut. I've got to stop the bleeding of the cut. So each action of the cut itself and the chemicals that respond to that are going to send in agents to clot the blood. But once that blood has clotted and I'm no longer bleeding, stop, right? So amplify to get the bleeding to stop, and then just stop that whole action, because now I'm done. I'm past that point. I have completed that action. I don't need to keep doing that. Where negative feedback is constantly staying at the same, this is, I have a situation that needs to be taken care of, and it's got to be done, and then when it's done, okay? Protein digestion is another one. Nerve signals. Lactation, feeding your baby. If you don't nurse your child, you're going to stop producing milk. So the more you nurse the child, the more milk you produce. The longer you nurse, the longer you're going to produce milk. But once you stop, it's over with. So we're constantly going positive feedback. In other words, I am nursing, I'm nursing, and then I stop nursing. That child's weaned, I stop producing milk, right? Positive feedback. Necessary, but not very common. It's not everything works this way. But those things that do work this way are very, very, you need them to happen, right? So summary here with positive feedback, it actually increases or accelerates those actions. Where negative feedback, I'm always trying to decrease those actions and come back to normal. This one's trying to take me away from normal as much as possible till I'm done and then come back. So you're getting more and more instability for that time period, more and more chaos, again, for that time period. But once it's done, you have completed whatever action it is you had to complete. Now I can return to normal. Okay. But I'm not going to have to do this again, like right away. It's going to be whenever that comes up, whenever I have another child. It's not going to be tomorrow. It's not going to be later on in the day. It's going to be, years down the road. So it's for that time period only. And like I said, it's not very common. There's only a few types that are necessary for childbirth. They're short-lived compared to to negative feedback systems, and they're necessary for those actions themselves. Okay. So only infrequent events, not something you would want to do daily. I wouldn't want to do childbirth daily. So this is not the common. Negative feedback is the common loop. Positive feedback is the uncommon loop, because it's not very often that you're going to see this occur, or not very many instances that you'll see that occur. Here's where positive feedback can go wrong, though. So if you get a temperature, so, usually you walk outside, it's hot, you're going to sweat, and you're going to bring it back down. Well, if you get sick, your body temperature is going to go above what is considered a normal range. It's necessary for that time period. You need to take it above normal, 100 degrees or so, because that is going to make it uncomfortable for the microorganism that has just infected you. Okay. They like your body temperature too. They want to stay at your body temperature, and at your body temperature, they can make lots of new little microorganisms to spread throughout you. But if you increase the body temperature, you're going to reduce their reproductive rate. So they stop reproducing as much. So that's why we do that. We increase our temperature when we're sick. It makes us feel bad, but it also makes the pathogens feel bad. So they can't reproduce as quickly. Okay. So what happens then is, in some cases, you raise that temperature, right? And it works the right way. And then after you're sick, it comes back down again. But once it starts getting too high, 100 degrees, you're good. Let that thing run. But if it gets, above 101, we're getting to 102, you need to bring it back down. Because as uncomfortable as those pathogens may be, your cells are going to start being damaged too. So we don't want it to be too high, because you don't want your body temperature to keep raising up and your cells to be damaged. But there is a point. I'm raising that temperature, I'm raising that temperature, I'm raising that temperature. Your body says, this is dangerous. I'm going to have cell damage. I need to stop doing this. So it puts in work to try and stop it. But the very work that it's doing to try and stop this is actually having the opposite effect, and it's making it increase. So it's producing heat even faster by increasing the metabolic rate, by trying to rectify the damage that's being done, and it's bad news all around. So that it reinforces its positive actions, and then at some point, you just can't. Your body can't handle it. Too many cells, too many tissues, too many organs succumb to that temperature, and you're done at that point. So that would be positive feedback gone bad, gone wrong. Again, you want a raised temperature when you're ill. If you have a pathogen of some sort, you want to raise a temperature, but you don't want it to go too high. You kind of want it to maybe higher than normal, but not too high. And then eventually, after you're not sick anymore, come back down. Well, with life-threatening, it just keeps going and going and going. Too high, and it won't come down. You got to take drastic action. You got to ice bath or do something to get that body temperature back down, because your body can't do it itself. This is a video I'm going to post on D2L for you. It's shows positive and negative feedback. It uses a lot of terms that really you are not responsible for at this point. Next semester, when you're talking about endocrine system, you can learn all about estrogens and luteinizing hormones and whatever else they mention in here. Just really pay attention when you watch this about how the positive feedback is happening. So the more that's released from here is causing the pituitary to release more, and this is and so your levels start to increase, and then at some point, after ovulation occurs, it says stop that, and so the levels come back down again. So just really watch the positive and the negative feedback on that when you go through that. Don't pay attention to all the names of the hormones and what's going on with the pituitary and stuff. You'll learn that later. All right, so going back to how we're going to study in here, so another sort of skipping along. We learned what gross meant. Gross means the looking at the larger picture of something. So gross anatomy is one of those things we're going to do in this class as we study through, especially in labs. You're going to look at virtual models. You can look at models. You're going to look at virtual models. We're going to have the ability to kind of, I'll give you some pointers on some different 3D types of websites and stuff that you can look at and stuff too. But basically, you're looking at the whole structure. So a whole muscle, the whole chest that has several muscles or something on it. So that would be gross anatomy. So looking at models of things. We're also going to look at microscopic anatomy. So that'll be looking at your cells, individual cells, or cells in groups as tissues, and structural, that kind of stuff. So that's kind of using a microscope or using something that would show you what a microscope is looking at, depending on how we're going to go about that. Radiological, we're not going to do a lot in this class, but it's another way of looking at things. And I'm going to show you some x-rays, some CT scans and stuff throughout the class that show you interior. It's a way of looking interior of the body without actually doing any physical damage. So we can go in non-invasive. We can go in, you can look and see, you know, for instance, an x-ray of a bone. The doctor can see if the bone is broken. You can use CT scans and MRIs to see damaged other soft tissues that are damaged, or maybe uses of glucose in the brain and that kind of stuff. So radiological is another way of studying the body or looking at the body without actually physically having to go into the body. Here's something you're going to need to go over in lab. So we're going to, you know, I told you a lot of this overlaps between lecture and lab. So this is one of those things that I'm going to talk about in here. And it's, if I do it in lecture, it will be something that you're responsible for on the lecture test. So pay attention to both ends, lecture and lab for this. They overlap in this area. But we have these different parts of the body that hold structures, and they're isolated little areas to a certain extent. So they have like boundaries around the outside. So you do have these that are called cavities. So our main body cavity is the cranial cavity that has the brain in it. And then that is continuous with this green one down here, which is called the vertebral canal. Both of those are part of, it's not on there, what we call the dorsal cavity, okay? So it's a larger cavity called the dorsal cavity that is made up of cranial and the vertebral here. Now, terms to start using all the time. One of those is dorsal. Dorsal means backside. Ventral means the front side. So that's the belly side. Okay, so this is the belly side. This is ventral. This on this guy, this is the dorsal side here. Since the vertebral column canal runs down the back side of these that you see in pink and blue and green in the front here, runs behind that, it's running to the dorsal portion of that. That's why it's all called the dorsal cavity. Then part of that ventral cavity, I'm going to write it again, just had it right there. The ventral cavity is subdivided into these right here. So what you see in pink is thoracic. Thoracic has its own subdivision. So let's come over to this other picture. So here is thoracic from here to here, right? Within the thoracic cavity, the chest, you have the pleural cavities, which are the lungs. Things to keep in mind also as we talk about anatomy. Anatomy is all about the individual you're looking at, okay? So we have something called the anatomical position. Anatomical position is so that we can refer to things as left and right, you know, looking this guy from his side or looking at him from his front or looking at him from his back kind of gets you confused here. But anatomical position is sort of just the standardized position. You can look at somebody and say, this is how I'm always going to refer to them. So they're looking forward at you, like this guy over here on right here. He's looking forward at you. His arms are straight down and his palms would be facing you, okay? And then his legs are straight in front of him. So it's looking from the front. And you have to look at him and go, this is his left and his right. So as I'm writing on the screen, right, I'm using my right hand to write. So that's this side, and then this side is my left hand. But that's not what I'm looking. I'm not talking about me. I'm talking about this guy. So this is his left and this is his right. And you always have to refer to the person that you're looking at, not to you. It is not your heart. It is not your lung. It is not your stomach. It is your patient, in this case, or whatever, your models, left and right. So I always want you to realize that you're going to have to look at opposites. You know, my right is over here, but his right's there. So I'm looking at this opposite. So on here, going back to the thoracic cavity, this is the left pleural. Pleural refers to lungs. So left pleural cavity right here, and then this would be the right pleural cavity. Also in the thoracic cavity, you have this one right here where the heart is housed. That is the pericardial cavity. There is no left and right because there's only one heart. Okay, so pleural cavities are in the thoracic, left and right. Also the pericardial. And then there's this other one right in here. The mediastinum, they show it in purple right here, runs here and it runs behind the pericardial. So you can see it between the lungs. It really runs between the lungs, but you can see it between there and then sort of behind the heart. That's called the mediastinum. So that's part of the thoracic cavity there. Dividing the thoracic cavity. So here's cranial, right? There's the vertebral. Thoracic here. Dividing thoracic from everything below that is a structure, muscular structure called the diaphragm. So there's a physical divide between thoracic and what we call an abdominal pelvic cavity. And the abdominal pelvic, like the thoracic, has minor sections. Abdominal pelvic can be divided into sections, but sadly, there's no membranes that really divide. It's kind of area more so than it is. Here's a membrane that surrounds this area, like the heart is surrounded by a membrane, so you know that's pericardial. This one's just kind of area. So the top part is abdominal and the bottom part is pelvic. Okay, and you can see it from the side over here too. Those thoracic and abdominal pelvic are both part of that ventral. Okay, so we have these big divisions and then we have these subdivisions down. You need to know all of those cavities. You need to know that abdominal and pelvic are part of the abdominal pelvic as a whole, and then abdominal pelvic and thoracic are part of ventral. So know all of those like subdivisions of that. Here it is from another side. So again, and there's with dorsal. So cranial and spinal cavity are both part of the dorsal, whereas that ventral is the thoracic. Don't forget your subdivisions, pleural, pericardial, and mediastinum. And then here's the diaphragm right here. And then your abdominal pelvic can be subdivided into abdominal and pelvic. All right. Most of these cavities, except for the abdominal pelvic, but most of the cavities and stuff are going to be separated by layers of tissue. Okay, we call those serous membranes. So they have this membrane. So like the pericardial I showed you, here's the pericardial cavity. The heart is inside of here, but around it is actually 2 layers of what we call serous membranes. So that pericardial cavity is defined by those layers. And each of those layers, there's 2 layers, okay? 2 layers of that serous membrane. You have a visceral and you have a parietal. You have to get to know this right away. Visceral refers to organ. So as I'm looking at my heart right here, I wish I could figure out how to do different colors. That would be nice. As I'm looking at my heart, and I have 2 layers, right? And let's just draw it over. I have a first layer of a serous membrane and I have a second layer. And my heart's right in the center. The layer that is right next to the heart, that's your visceral layer. The layer that's furthest away from your organ or closest to your body cavity is what we call parietal, okay? So my heart is laying in here, and it has 2 layers on the outside. And then we have fluid. So you can have fluid between the heart and the visceral, and between the visceral and the parietal layers. So there's fluid in between these layers of very small amount, but there's still fluid between those. That's why it's called serous. All right, so in the thoracic cavity, we're going to have the pleura, which are around the lungs. Okay, so I have the visceral pleura, which are going to be directly around the lungs. And then I have the parietal that lays on the outside of that. Then you have the pericardium, which I was attempting to draw up there. That's around the heart. Okay, so I have the visceral that's directly laying on the heart, and then the parietal that is the separation from that. Then we also have the abdominal pelvic membranes. And again, there's 2 sets of this. You have the peritoneum, which is upper abdominal, so parietal and visceral. Visceral would be around the organs. Parietal is around the body, lines the body cavity, so it's outside of the organs. And then the same with the perineum down in the pelvic region, the visceral closest to the organs, parietal furthest away. So when I look at this, you can start with this picture over here in the corner. You see that I have a human body, and you've got the lungs and the heart and all the abdominal stuff. So this section is taking a cross section. So like I just cut right here across my body and then flipped it so you could look at it. So this is this section, and now I'm looking directly at this. So this is lung tissue right here. This is a lung over here, okay? Here's your vertebra right there. Here's your heart, okay? Notice that they have, you've got the fat and the skin on the outside. Notice you're going to have 2 layers of that tissue. So remember, around the lungs, it's called the pleura. I have the visceral and the parietal going on right there. Visceral, see how it's right on the lung? So it's right here on the lung. Parietal, there's a little gap, and then it's away from the lung. It's closest to the body cavity of the 2 layers. In that gap in between is fluid. So you have a little bit of fluid. That fluid and those layers allow the lungs and the heart and everything to expand and get smaller and expand and get smaller without rubbing against each other. So they have space. They have space to do whatever they're supposed to do and change shape without putting pressure on something else. Now, if you get too much fluid in there, like in the heart there, it's gonna crush in onto the heart, or it's going to crush in on the lungs, and that's a whole other issue. But this is normal to have a little bit of fluid in there, okay? And here, again, I have the same for the pericardium. Visceral layer. I think my arrows may have moved, but the visceral is right up next to the heart. And then the parietal is the one that's away from it. So the second layer out from it. You can see it better probably in this area. Visceral here, and then parietal over there, okay? And then this is abdominal, so the upper abdomen region through the liver. You've got liver right here, stomach, looks like intestine right there. There's vertebra again. I've got spleen. Anyway, so, oh no, that's kidney. Okay, sorry. Kidney. And here's the other kidney. There's the intestine. So taking that section right there and then flipping it so you can look at it. Once again, all of these organs are called viscera. So the layer that is closest to those organs, that's called the visceral. And since it's upper abdomen, that's peritoneum. And then the one that's furthest away from those organs, closest to the body wall, is the parietal peritoneum. If I were to go lower down here, it would be the same, but it's the perineum. Okay, so we have visceral and we have parietal perineum. There's our anatomical position that I was talking about. So notice the palms are face forward, the arms are down, the legs are facing, you got the toes face forward towards you. His face is looking at you, so you're looking at the front of the body. And remember then that it is his left and right. So this is the left side, this is the right side. So when I refer to a lung, this is going to be his right lung. This would be his left lung. You have to do the opposite thing of what yours is, because it is not, I'm not him. So it's not my right and left, it's his right and left. The same with the arms. So this is his right arm, this is his left arm. And if you have to kind of flip your body to kind of remember, or cross your arms and say, okay, your right's over here and left's over here, then do that to remember that. But don't come back and say, hey, is it my right and left? No, it's always everything from the tissue layer to the bone to whatever. It's their right and left. Okay, so you can always turn it and flip it to put it on you, but remember, as you're looking straight at them, it's their right and left, not yours. Thumbs out too, don't forget the thumbs out. And the reason we do the thumbs out, by the way, see his little thumb here, it's because you have 2 bones that run down here. This bone that runs right along with the thumb is called the radius, and the radius, his job is to rotate. So if I have my thumb facing inwards, so if you've turned the palm, the radius actually shifts position. So the radius comes across and would be this way when he turns his hand. So it turns with relationship, and that kind of gets confusing. So we want to standardize it. So we put thumbs out. So the radius is here, and the ulna is right there. Okay. That way you have it here. So that way the ulna is always more medial towards the midline, and the radius is more what we call lateral, out from the midline. All right, other terms. Superior just means above, and these are all relative. Key here. Everybody wants them to be like objective. It's always superior. Well, it's not superior. My nose is superior to my lips, but my nose is inferior to my forehead, right? So the nose is not superior. You can't just say my nose is superior. It has to be in relationship to something else. It's only superior to anything that's below it. So lips, chin, whatever, it's superior, but it's inferior to anything above it. So you have to qualify your statements and say, what is it superior to, or what is it inferior to? And we'll name things also this way. So like on the heart, you have, oh God, I got to draw a heart again. Here we go. Here's my heart again. Here's the atria. That was probably better than last time. Here's the ventricles down in here. Okay, so we have vessels coming in to the heart from both sides, but I'm just going to draw this on the right side of the heart. The blood vessels coming in. So this one is coming in and it brings in blood from the top part of the body. So it's called the superior vena cava. Whereas this lower vessel is doing the exact same thing, but bringing blood in from the lower part of the body. So it's called the inferior vena cava. That's a relationship between them. This blood vessel is lower than this one, so it's inferior to that one. So superior and inferior. It's coming from the inferior portion of the body versus the superior portion of the body. So remember, there are qualifiers there, and there are naming systems that go along with that. Anterior means towards the front in humans and towards the back. And what it really means is your direction of movement. So anterior is like what part of your body is moving forward. So if you're a human, we stand upright, right? So our belly side moves forward. But if you're a dog, they're quadrupeds and their head is anterior and their head moves forward. Their belly is actually facing down. So that's not considered anterior to them. But we're going to deal with humans. So let's look at that. So the things that are going to be the same then, anterior in humans, anterior and ventral are pretty much the same because remember, ventral means belly side. Okay. Anterior means the front moving forward. Posterior for a dog, right? Posterior is the tail end because that's the end that's dragging behind as they're going forward. That's behind the front end. But for us, posterior, our back is dragging behind, is behind us. So posterior is towards the back in humans, and it's also going to be used almost interchangeably with many things with dorsal because that means the back side, right? And when you're trying to remember this, one of the things I remember, a dorsal fin in the shark is on their back. So you think back, dorsal. Okay, dorsal fin. Don't remember they're at a different angle too. Medial just means towards the midline. So as I'm dealing with a person here, here's their body with the arms coming down. Anything towards that center line, going in towards that center line is more medial. And again, it's still a relative position. So the heart is medial to either one of those lungs. So here's the lungs here, right? The heart is medial. Likewise, lateral means towards the outside. So it means going outwards. So the lungs would be lateral to the heart. So you have to qualify this. They're lateral, they're towards the sides, and you have two of those. Bilateral, bi just means two. So bilateral means they're paired. You have two lungs. They're bilateral. They're on both sides of the body. You have two kidneys. They're bilateral, paired, one on each side of the body. You don't have two noses, but you do have two nostrils, right? So some of those can be paired, some aren't. Ipsilateral. Ipsi means same. So ipsilateral means I'm talking about two things on the same side of the body. So it can't be my right lung and my left lung because they're opposite sides. It's my right lung and my right kidney, though, are ipsilateral to themselves because they're both, here's my little guy again, arms, body. So right lung, right kidney are on the same side of the body. But right lung and left lung are contralateral. That means opposite because they're opposite sides of each other. Or right lung and left kidney, right? So anything that's opposite are going to be contralateral. Doesn't have to be the same organ because ipsi's not. Proximal means closer to the torso. This is confusing, all right? These two terms right here, I should use one of these pictures on the side. These two terms refer to your appendages. So your arms and your legs, okay? That's what we're referring to when we talk about proximal and distal. Here's the problem. I can't really say that one's, in most cases, lateral or medial, because I can move my arms around. I can move my arms up over my head. I can move them out to the side. I can move them out all kinds of places. So they can change position, even though we technically want to stick with anatomical position. So what we do with them when we talk about the, here's an arm here. Okay, there's the trunk. Okay, so what we want to do, and it could be the same with the legs, we talk about where the attachment point is. So my arm coming off of here is attached by that pectoral girdle. So right here, your shoulders. Your legs are going to be attached lower down by your pelvic girdle. But again, your legs come off of the torso. Anything that is further away from this attachment point is called distal. Anything that is closer is going to be proximal. And again, it's relative. All right. So your elbow, here's my arm, my elbow could be proximal, it could be distal. It depends on what I'm talking about. So my elbow, if, oh, good Lord, now I got to draw a hand. There you go. There's your hand. All right. The elbow is proximal because it's closer to this joint than the hand is, right, or the wrist, but it would be distal from that bone that's right there. So your humerus that's right here. The humerus would actually be proximal compared to the elbow. The elbow is distal compared to that. So again, distal just means further away from that joint, from this attachment point right here. Proximal means closer to that. And you have to be specific. I have bones in my fingers. When you look at your fingers, where's my, okay, I have 1, 2, 3 bones right here. This one, this little bone that bends right here is distal compared to either one of these two. But this one and this one is proximal of those 3, right? But again, this bone in the middle, it's proximal compared to this one, but it's distal compared to this one, right? So you really have to be careful how you're using those terms. It has to do with their relationship, positional to each other. All right, superficial just means nearer the surface. So your skin, your outer layers of your skin, your epidermis is superficial to the subcutaneous fat layers. But again, relative, because my subcutaneous fat layers are still superficial to the muscles, right, that are laying underneath them and deeper to them. And deep just means more internal. So again, you use these as sort of relationships to each other. And then internal means inside and external means outside. That should be easy enough. All right, so looking at these then, I want you to go through it in your head as I'm going through it. Number 1, I have an arrow facing upwards. So that one would be, could be actually 2, but of the words you learned, it's superior, right? The other term, I think they've got for 7. Oop, it's going too fast. 2, going down is inferior. 3, going towards the midline is medial. 4, going out is lateral. 5 is proximal, going towards that attachment, and 6 would be distal, going away from that attachment. 7 is cranial, and 8 is caudal. I told you that there could be, 2 terms for superior and cranial. Cranial just means towards the head. Caudal means tail, so anything that is going posterior or inferior, is also caudal. I was thinking of I do cat dissections too. The palm of your hand is called palmar, so that's that one. And then the bottom of your foot, not your foot itself, but the bottom of your foot is plantar. All right. Again, towards the belly. So here's the vertebra. So always find a spot that gives you some sort of frame of reference. The vertebra tells you this is the dorsal side. Okay. So dorsal here, also known as posterior. That means if that's dorsal, this is ventral or anterior. So ventral is another term for the anterior as far as belly side there. And then peripheral just means towards that surface. So the other name is superficial. Body planes, we're going to do cross, and you did a cross section when I talked about the serous membranes, but there's other ways to cut the body, and each division, each way to cut something gives you a different perspective of those organs or those structures. So we look at things in different ways. Sagittal just means it cuts down and makes a left and a right. Okay, it doesn't tell you where. It could be straight down the center, like I'm doing with the pen. So right down the center is a sagittal cut, but could also be off to the side. So this is still a sagittal cut. It could be anywhere in between those or going the opposite direction. So a sagittal plane is just this left and right of some sort. Okay, also called a median. You need to learn one or the other. You don't really need to. I would go with sagittal, but because you're going to see that come up again. But either is a correct term. Mid-sagittal is specifically down the center. So where I was showing you with the pen straight down the center. So any of these is sagittal, but mid-sagittal is specific, and it says it's equal left and right sections. Then I have transverse, also known as horizontal. Again, either term's fine. That divides you from a superior and an inferior view. So our cranial versus caudal also is another term, cranial and caudal. But superior, the top, and the inferior. And again, it doesn't have to be right there in the chest. It could be anywhere. I could do a transverse cut right here on my head. I can do it right up here. I can just barely get it and it still has a transverse cut. It's just a cut that goes this direction or horizontal. And then I can divide the front from the back, right? So dividing your anterior and your posterior from each other. This is called a coronal plane, okay? Also called frontal. So once again, when I ask you for a name or something, if I ask you to write it down, one or the other is fine. You don't have to put both, but I would kind of learn both because it depends on the structure. Sometimes they refer to them as coronal, and sometimes you'll see people refer to them as frontal. It all means the same thing, but you'll hear both, okay? I just don't require you to actually write both if you need to. All right, and there's another view of it. So you've got the different cuts through there that they're showing you all at once. Again, a little review. Here's the brain, so it doesn't have to be an entire person. Notice the differences between each of these brain sections when you do this. If I do a sagittal cut, which is the right-left thing, right? Right-left. That's going to give me a view that shows, this is called the cortex in here, and then I've got the diencephalon and stuff in the middle, and brainstem coming down here in the cerebellum. Notice how I can see these structures here, and you can see this one, corpus callosum right here. In that view, this is a view right here cutting through like this. So it's the same brain, or it is a brain from a human, but it gives you an entirely different view of it. So where I see corpus callosum right here, this is it right here on this transverse cut. So I get sort of a different view of that. Here's that diencephalon, here's the diencephalon here. So I'm getting a different type of outlook from it. And then frontal coronal, here's that corpus callosum coming across here. And I can see the right and the left. And I can see the white and the cortex and the different matters in there. And they do look different from each other. So it gives you some different aspect to get a view from it. And of course, if I change that, if I move this, and cut right here or right here, I'm going to get even a different view than I get from that one section. As far as organs go, when we start to cut organs, and this would be like a bone, this looks like a bone in this picture, or cells or tissues or something like that, usually smaller objects, you can do different cuts. A lot of times you'll see this with microscope slides, or use these terms. But if I go across here, which would on the larger body itself, it's homologous to like a transverse section, but on a bone or an organ, we call it a cross section of something. Oblique is just at that angle, and then longitudinal takes the length of it and cuts it in half down. Okay, and you do get different views of things from that too. Notice in a longitudinal, I can see all the way down the interior of this bone, where here I just get one little view of it. Right? This is a little bit larger, but still a smaller view. So it depends on what I want to look at. You're going to need to know the abdominal subdivisions. So there's regions When we say regions, there's 9 regions. When we say quadrants, that means 4, and that's got different names. Start in the easiest spot, and that's the center. Okay, so right here in the center, you have the umbilical, and notice you also have mostly the small intestine in that region. So kind of know what's located in that region, and then go up and down from there. So straight up is called the epigastric, and you see stomach in there and a little bit of the liver in there, or part of the liver in there. Hypogastric, hypo means low. We've got bladder, and we've got some more of the small intestine in there. And then we have right and left. And remember, it's his right and his left, not your right and left. So directly right and directly left are the lumbar, right lumbar and left lumbar. Above that, we have what's called a hypochondriac. So we have right hypochondriac and left hypochondriac. And then below, 2 names for this, and it depends on your textbook. It's sometimes referred to as iliac. It's thundering outside, so they're going nuts. Or inguinal. Okay, either one's fine with me. But also kind of learn, what's located in those regions, hip bones and the iliac or inguinal. When I ask you for quadrants, there's only 4 quadrants. So quad means 4. So take that. You take the abdominal region and you divide it into 4, and still right in the center, we're still right in the middle of the small intestine. So you can see these letters, LUQ and RUQ. I'm okay if you use that, but just remember to get them in order, because ULQ does not mean the same thing as LUQ. So if you're not sure, was it lower or upper quadrant, or was it upper lower? If you're not sure, then spell it out, okay? Because if you get those words out of order, I at least know what those letters are meaning, because you're telling me what they're meaning. So left upper quadrant, make sure you get that right on there. And then right upper, and then right lower and left lower, and kind of know what's located in those quadrants too. And then you're going to have to know body regions. I'm not going to go through all these. This is in your lab book and lab information and stuff, but you do need to go through and do this. And my best advice, flashcards. Use flashcards for this, okay? Also use your body. Touch and say. If you just look at something and you try and memorize it, this goes throughout the whole semester and next semester and everything you do. If you just try and memorize it straight from a picture, it's so much harder to do. You have to actually verbalize. So say it, touch it, and then repeat it. Say it, touch it, repeat it. Keep doing it. Plus flashcards. The more different ways you try of learning something, the better it's going to get into your long-term memory versus into some sort of short-term memory where you forgot it. I learned, I've learned cephalic, and then I've gone down here and learned sural, and I forgot what cephalic was. Go over and over and over again. Repeat, repeat, repeat. Okay? But you do need to know those, and you will be responsible for writing those names out on lab practicals. So you've got to know these terms. And that's the end of chapter 1. See you guys in chapter 2.